Hello, everyone, and welcome to our virtual Intersections gathering. My name is Christian Mehta, and I am the AVP of Engagement at our university. I am so delighted to open today's Intersections event. Intersections is our program for alumni and friends that brings alumni and experts from our community together on topics that matter to all of us. Needless to say, today's discussion is particularly important as we look into the future of healthcare and medical education. Before we begin this event, I would like to acknowledge the land on which our university is located. Toronto is in the Dish with One Spoon territory. The Dish with One Spoon is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. And as you reflect on today's discussion, I invite you to also consider your relationship to the land and how we can continue to collaborate on decolonization and reciprocity. We are delighted to have Dr. Adam Kassam and Dr. Josephine Wong join Dr. Stephen List today. Dr. List is Ryerson's Vice President of Research and Innovation and a professor of chemistry and biology in the Faculty of Science. He is an experienced academic leader who has played a significant role in the advancement of university education at the undergraduate and graduate levels at several universities in Canada. Dr. List chairs the University Planning Committee to establish a proposal for a new medical school here at our university, and we are so fortunate to have him tell us more and to lead this conversation. Dr. List, over to you.
Well, thank you very much, Christian, for the opportunity and the introduction. I really appreciate it, and it's delightful to be here to be able to share our story of the School of Medicine development underway and the journey behind it. And I have a story I would like to share with you in a minute or so, but I am also very pleased to be joined by a distinguished group of panelists who are joining me today. Dr. Josephine Wong, who's a professor in nursing at Ryerson University with extensive experience in critical public health and urban health, including development of public health access, equity policy, and practice frameworks and large-scale health communication campaigns. She collaborates with marginalized communities to develop, implement, and evaluate capacity building health promotion and collective empowerment programs. She also supervises and mentors research trainees, the master, doctoral, and postdoctoral levels. I'm just delighted that Josephine is with us today and represents really a tremendous breadth and depth of our scholarship and research and our faculty in interprofessional healthcare training and education and research, and a representative of the strengths that we come from in this area. Delighted that Dr. Adam Kassam is also here with us today. He is the president of the Ontario Medical Association and is dedicated to sharing his knowledge about public health, diversity and equity in research and education with the medical community and the public. Dr. Kassam has written for CNN, The Atlantic, CBC, Globe and Mail, and has appeared on CTV, TVO, CPAC, and Global News, and has lots to say, but draws from a considerable range of experience, including as a clinician, as well as his commitment to public service and to the Ontario Medical Association. And he's been a very powerful champion for change in our healthcare system. But before I come back to our guests and the conversation, I'd like to spend a bit more time really talking to you about the story behind our development of the School of Medicine, which I'm very excited and I'm very privileged to have had the opportunity to chair the planning committee at the university. So I'm going to share a bit of background on our planning process. So at the end of March, the province provided the university with a $1 million planning grant to develop a business case for the medical school. And in July, the city of Brampton matched that to support with a $1 million investment. The proposal details the university's approach to health education with a focus on primary care, expanded use of technology to better meet patient needs, interprofessional practice, and the provision of culturally sensitive care. So why are we proposing to establish a School of Medicine? Well, first, the pandemic certainly exposed the weaknesses in our healthcare system, and the current structure is simply not sustainable, and fast-growing communities such as Brampton have experienced some of the greatest challenges. This has really laid bare inequities in our healthcare system, and many of the cracks appearing long before the pandemic, but only to be amplified by the circumstances surrounding the pandemic and looking to the future of healthcare. We need a new kind of healthcare based on community needs that is inclusive of everyone from every background, where diversity is recognized and appreciated. And our university can offer a new approach to medical education in Ontario and in Canada, and is positioned to take a leading role in healthcare reform. It's our intention to be that agent of change. An important activity over the past several months, and one of the main ways which we have used from the spring consultations, is in the development of the draft vision, mission, and value statements that will frame the School of Medicine planning. Our vision, a healthier society, together reflects our aspirational goal of health equity and achieving it in partnership with communities. Our mission is dedicated to improving the health and well-being of individuals, families, and communities across Ontario and Canada, with a focus on the use of primary care needs of diverse and medically underserved populations through community-engaged education, scholarship, and service. We are committed to educating students to become compassionate, respectful, and future-ready clinicians who provide outstanding holistic healthcare, who lead in a health system transformation. We strive for equity in all that we do, and we commit to truth, reconciliation, anti-racism, and justice to achieve inclusion and optimal health for all. So in drafting this mission statement, we took seriously the need for a clear commitment to equity, diversity, and inclusion, as well as reconciliation. And the first statement in our mission statement anchors the medical school and social accountability. And we'll speak into this directly in a few moments. The sentence also reflects our community-engaged approach to medical education. The second sentence highlights our commitment to train a different type of physician, physicians who have culturally sensitive and practice with humility, who are compassionate and respectful, and who provide outstanding holistic healthcare and who become health transformation leaders and advocates, and the ability to work interprofessionally. Of course, we are committed to truth, reconciliation, anti-racism, and social justice, as I've indicated before. Our values are health equity, community engagement, equity, diversity, inclusion, and mutual respect, integrity, well-being, leadership, reconciliation, and Indigenous health. These draft statements serve as a foundation for future planning. They are designed to communicate the direction of the School of Medicine and will guide decisions about resource allocation, curriculum, and teaching and learning. We are developing the medical school not just for the community, but with the community. We have been consulting extensively with the community in Brampton and Peel Region. The consultations are being led by our University Relations Office and of course, the School of Medicine's Director of Community Engagement, with guidance from our elder, Joanne Dallaire. And we acknowledge that there are many people contributing to this wonderful initiative. What we've learned to date from the consultations is the 5 pillars of the School of Medicine are resonating well with community members. They are particularly excited about community-centered care, social determinants of health, and the focus on technology. And when asked which of the pillars is the most important, people said that they are all important and overlapping. And many believe health equity, EDI, patient-centered care, and excellence are also important. So if you are interested in learning more about the School of Medicine, please feel free to contact us at medicine@ryerson.ca with any questions or comments. I would like to say that we had taken an approach at the outset of working in a very public way in terms of our consultations and engagement with the community in an iterative framework to reflect the importance of that community engagement in not only in the development of the proposal, but the establishment of the school and how this school will run. And it also is our commitment to our mission and values. Importantly, we have been working iteratively with government as well. And while we expect that it will be some time over the next few months before all our planning processes are complete, we can assure you that we are not waiting to that point in time in our consultations and discussions and with all stakeholders. And we look forward to hearing from you and sharing more with of these details as we move forward. So thank you very much for allowing me the few minutes ahead of this panel to share the story of our School of Medicine. So again, delighted to have Dr. Josephine Wong and Dr. Adam Kassam with us today. And so looking to both of your perspectives, sitting on the respective perches, looking where you currently sit in the healthcare system, from where you've come from, and where you anticipate the future holds, looking beyond the horizon. So I'd like to invite each one of you to take a few minutes to talk about, the past in terms of the important influences that guided you to your respective roles in healthcare practice and education, and where you see the current system currently and the opportunity for change to make sure that we have the healthcare system for the future. So I'm going to turn to Dr. Kassam to begin with a few opening remarks. Over to you, Dr. Kassam.
Yeah, thanks so much, Stephen, and thank you so much for the invitation to speak and to be invited here to dialogue. I know it's in a very important and frankly a very turbulent time in healthcare for obvious reasons. And while we start thinking about how are we going to deal with Omicron and the pandemic response right now and this changing and shifting environment that we find ourselves in, I think it's also important that we also be mindful of what a future state of healthcare might look like. It's why the OMA has been engaged in one of the largest consultation processes in our 140-year history, which has included surveying members of the public to the tune of 8,000 of them over 600 communities. We've had healthcare stakeholder groups come together to give us some impression about what they believe some of the top priorities in healthcare should and hopefully will look like. And that includes universities, it includes other health groups and other stakeholders, but it also includes 1,600 physicians who are our members. We represent as an organization 43,000 physicians across the province in all corners of the province. And so it gives you some lens into where we are as far as an organization, who we serve, and then ultimately what our scope and mandate and reach is as far as patient care in the province. We, on average, treat approximately 350 to 360,000 patients a day. That's how many patient interactions happen in the province of Ontario, physician to patient. And so this is a large, heavy lift that the profession has been dealing with, obviously, for quite some time. And layered on top of that, the pandemic has proven to be quite challenging and has challenged some of our core thinking about our healthcare system writ large. And so when we think about transformation, and when I think about healthcare, I think it is helpful to frame it up in a lens of three major buckets. I think about prevention, intervention, and rehabilitation. Those are the three pillars of healthcare. Prevention, we think about vaccines, we think about social determinants of health, upstream factors to prevent disease. Unfortunately, people will get sick. And so how do we intervene at the appropriate time and at the appropriate, with the appropriate measure? And so intervention, which is treatment, whether it's in a hospital or in a clinic, that's really important as well. Being able to get people the care that they need at the time that they need it. And then finally, we have rehabilitation, which is focused on what is our transition plan for patients as they move back into their communities, back at home, back to work, all of these sort of transitions back into their daily lives. And so that's an area that I think that we need to focus on a little bit more. And sort of the pandemic has really fundamentally altered the way which not only medicine probably will be sort of structured into the future, but how we deliver care as well. And so this opportunity to think about a transformation is so crucial. And we think about a key number of different areas in that transformation roadmap, which we believe presents an opportunity for evolution and transformation. And so, and there are a number of key areas, Stephen, that within that platform, I'm happy to kind of expound upon, but just to give you your audience a bit of a lens, sort of those are the key three pillars: prevention, intervention, rehabilitation, layered on top of that with the pandemic and transformation. And what does that look like for a 21st century healthcare system that we're building together?
Well, thank you very much, Dr. Kassam. Dr. Wong, over to you.
Yes, thank you. Thank you for the opportunity to engage in this dialogue. I started out, I have my training in nursing, and I started out in pediatrics care, and then into adult ICU, and then into e-toxicology in critical care. And in my early years of practice, I noticed that when I was working with families and individuals and children, a lot of the social suffering actually was beyond the physical illnesses. It's really tied to what kind of social determinants, structural determinants that is happening in people's life. So then I changed to public health and community health. And in the early 1990s, when I was transitioning from clinical care to community health, I was also quite baffled by the kind of stigma and discrimination at that time experienced by people living with HIV. When I had tons of shifts coming in, and because nobody wanted to go and do home visit and care for people who are living with HIV. And when I was in the hospital, it's the same, people refusing to take care of patients who were dying of HIV. And so that inspired me to actually go and go beyond. And so I have been very blessed. In the last 15, 20 years, I had the opportunities to always work with interdisciplinary teams. So every research that I engage in, there's always a primary care physician. Very often I have a cultural psychiatrist on board. I have a clinician on board. Sometimes we work with communicable disease specialists. For instance, we have COVID-19 research going on. So I feel that this actually is really amazing, because when we bring all the disciplines together, medicine, social work, nursing, OT, all that together, we often challenge each other and we bring out really innovative ideas, and that help us to move forward. So we are able to actually not only do research to understand phenomena, but we have been doing research to actually come up with solutions that can intervene with the kind of health disparities and inequities that's experienced by very vulnerable and marginalized populations.
So thank you, Josephine. So just building on what you've been just been saying in the last moments about social determinants of health and the way in which it's driving also the interprofessional connections. And I know you've spoken with respect to that engagement in a public health perspective, and the way healthcare is in fact at the ground is beginning to look differently where it can and where it's possible. So building on that, thinking about the types of programming, including existing programs, whether it be in nursing or other areas of professional practice in health, where the social determinants of health are increasingly becoming more important. How do you see that figuring into a new school of medicine for training the next generation of physicians?
Well, maybe I'll talk a bit about that, and then Dr. Kassam can add on to it. I usually do not get excited over any new things, 100%. And because I always think that there is something missing, and I was actually quite excited to see the proposed plan with the 5 pillars that is being developed in our university, because I feel that those 5 pillars that's tied to community-centered care, which is something that I really truly believe in, and I've seen evidence, and also about culturally safe, culturally inclusive kind of care, innovation with technology, supporting, the well-being of populations through interdisciplinary collaboration, as well as like the interprofessional and caring for elderly people. The COVID-19 pandemic had been very disheartening. I went through really emotional challenges in a sense, because we're doing COVID-19. I witnessed the kind of racism that came out, and watching elderly people dying. And not only that, elderly people who are in isolation, suffering from mental health challenges, and we're in lockdown and all that stuff. So I see these 5 pillars converging to actually produce social innovation. And I'm not talking about innovation tied to technology, AI and big data and that kind of stuff. I'm talking about social innovation where we come together across discipline with the same kind of commitment towards diversity, equity, inclusion, so that we will be coming out with solutions for our healthcare system right now that is not functioning very well. Nurses, stressed out, physicians are talking about leaving their profession, but now we will have an innovative way to mobilize, motivate, so that we'll come up with this innovative solution that is not only technological, medicine focus, but it's really a much more comprehensive and more holistic way. So I'm actually quite excited, and I couldn't believe why I'm so excited, but I'm excited.
Dr. Kassam, so you oversee and lead a large organization of physicians in Ontario. And of course, hearing from that community in terms of the pressures and that they're facing today, and thinking about the way in which medicine needs to evolve to better serve the communities. What is your framing of the role of the social determinants of health in preparation of the next generation of clinicians?
Well, I think it's helpful to frame what we are experiencing in the health sector right now, as far as the health human resource crunch that we experience in real time, in real ways, and which is highly regionalized. And we know that there have been physician shortages chronically for decades in this province. In fact, there's 1 million people in the province of Ontario that are unattached, meaning that they don't have access to a family doctor. We know that 2 million people that are expected to immigrate to the Golden Horseshoe over the coming 10 years, in the next decade. How are we going to serve the patient needs or the healthcare needs of this growing, and what we are finding is an aging and more complex patient population. So not only are we expecting health human resourcing to be even more stretched, but we're also expecting healthcare utilization to grow. And so there are organic factors through that growth that require our immediate attention. When we think about health human resources from a medical school perspective, and this is something that I think is important for your audience, but also for your institution to take to heart, which is it's great to have plans, and it's important to be thoughtful about your plans. It's important to be consultative in your approach and collaborative in your approach, and that's what you've been doing, I think, with this vision that you and your board and your leadership have developed. And it's a great plan. It really will come down to execution, right, at the end of the day. And execution is the operationalization of a vision. And you've already had very, I think, strong and robust partnerships that have been committed to the cause, whether it's political, whether it's institutional, organizational, civil society institutions, et cetera, in a variety of different locations, choosing intentionally to have this campus in Brampton, for example, building bridges to communities that will require care. And how does that happen organically, but more importantly, effectively? One of the things that we think about in our organization when we think about health human resourcing for the future is what does that pipeline look like? To train physicians for the future, it requires a very great deal amount of thought, but you can't stop at a medical school, right? It is of absolute no use. It is of absolute no use to build a medical school without the commensurate ability for those med students to then train in residency programs, right? So you don't want to build a program that ultimately does not lead to full licensure of independently trained physicians. And so as you're having these discussions, you have to be very mindful and thoughtful about what that pipeline looks like, start to finish, and what are the key considerations and, frankly, negotiations that have to happen in the right spaces to allow for care to be ultimately delivered to the communities that you're hoping to serve.
I appreciate hearing that. And postgraduate training is a very key part of the development of the medical school. And so it's clear that from our own planning purposes, it's looking at the platform programs that generate the pipeline, the connection to community. It's the journey through medical school. It's the governance of the School of Medicine. It's our continuous engagement with community, and it's a support for those postgraduate spaces and being a home to postgraduate training as well around the specializations, particularly relevant to primary care, and thinking also with that what that means too in terms of our research orientation as well, and of course, and what happens and how you support clinicians into the future in their careers, and I'm curious to that extent, and regardless of what area of healthcare that our graduates of our healthcare programs are practicing in an interprofessional framework, it strikes me that there's considerable pressure on individuals. So preparing the next generation of clinician and healthcare workers with respect to their resilience and ability to cope with the stresses and changes and the dynamics and many of the challenges as revealed through the pandemic have brought forward that's created burnout and mental health challenges and people walking away from the profession. How do we prepare our next generation clinicians and in order to support them better with respect to their own mental health, their ability to be resilient and be able to effectively practice and engage in the community in challenging situations? And so I am curious as to how we can better prepare individuals with respect to those challenges and how can we address that crisis?
Yeah, maybe I'll tackle that a little bit, and then Dr. Wong can build therein. It's an interesting way to pose the question, Stephen, about how do we prepare individuals to work in a system that is flawed. And so maybe the question that we need to be asking is how do we prepare a system to change to allow students and the future generation of clinicians to do their jobs effectively. And so that's sort of a broader systems level approach to change management in our healthcare sector that is desperately needed. How do we leverage technology to unlock some of the efficiencies that could be had for things like remote or rural care delivery? How do we make sure that we have the right types of physicians in the right places to deliver the right type of care at the right type of time? And so I think that when we think about system and when you're building a program which hopefully will fundamentally alter the landscape in which you work and practice and interface, but maybe even then have sort of this cross-pollination effect where you're affecting other institutions organically in a way that moves the ball down the field. How do you ensure that infrastructure is available, right? So when you talked a little bit about making sure that postgraduate medical education is part and parcel of this vision that you're experiencing and trying to build. Well, how do you make sure you have the proper educators, the proper facilities, the proper opportunities, both in the community and in other contexts, to ensure that the physician for the future is well prepared? And so it's a very complex question because there's so many moving parts and there's so many different stakeholders that have a vested interest in doing this and need to be brought together. And so when we think about, and when I reflect on my experience with the OMA and our organization over the past 20 months, we talk about having a necessity because of the pandemic response to collaborate, to come together, where there are silos being broken down and teamwork being expanded for obvious reasons, offloading and whatnot. So I think that should be an approach that we use for the future as we start to think about what a 21st century healthcare system, but also a 21st century healthcare medical training program would look like.
So, Josephine, I know in their background, I think that's the Daphne Cockwell Center and the building where the School of Nursing is housed. You've been very engaged in preparing that next generation of healthcare workers, and I know you work across the professions, including with physicians as well. But as an educator and somebody who's training for today, I mean, that's the interesting thing about healthcare education. It is actually training for today, and notwithstanding our desire to be agents of change, to create those system changes in the future, the reality is that our graduates are entering into moments of crises. And so maybe in that regard, how do you see how have you seen the programs evolve in nursing, for example, and the programs that you're involved with that have had to address this issue and to create professionals who can be resilient and take care of themselves as well as they enter these challenging roles?
Mm-hmm. So I totally agree with Dr. Kassam that whether physicians can actually continue to do their work and just like other healthcare professionals really depends on the systems. And this is the reason why, like I personally, I teach graduate students, I teach in the PhD program in urban health, I teach undergrad students, I mentor them. I feel that it's really important for students in medicine to learn about the political economy of healthcare systems. They need to have that understanding about how politics, economy actually come into place to play out how their everyday professional life is actually being shaped. And if we do not prepare our students to have that type of understanding, very often they only stay at the micro level to think that, oh, my taking care of patients, workload had gone up, patients load had gone up. I'm getting burned out, or they just feel that, oh, I just, cannot work with some of these individuals. Whereas if they actually can see how their practice as an individual healthcare providers is contextualized by the system, then it will be amazing how innovation will come out. Innovation will come when they can see that this is because there is system policy that's shaping that, but we can do something about it. And I think that medical education is very important in the sense that the reason why I'm excited about, the proposed medical school is because very often my student asks me that, but what can we do? And I said that, what, each one of us is part of the system. Of course, as an individual, many of us are constrained. It's not like we had the total freedom to change the world, but when we work collectively, we could do something. And so if students are able to actually see how they fit in, the other part, I also agree with Dr. Kassam talking about technology. And when I teach my student, I actually show them when I first started working in nursing, I have to regulate the drip of IV fluid. And I said, how many of you can do that? Nowadays, we have technology and it brings in safety. It support how we make decisions. But at the same time, this is where I get excited, is because the equity, the social determinants also come into play, so that we need to look at technology not as a neutral thing. How do we use technology to actually reduce the disparities? Disparities not only for our service user and patients, but also looking at how the system technology can help to also make it an equitable and good conditions for our healthcare providers to work in. So those are the type of things that I think we need to do through education. But as Dr. Kassam talked about, education on its own is not going to do. So students also need to understand about how they can shape policies, because policy came about through political processes. And if we do not support our students to develop those skills, then we're just going to put them out there and let them get stressed out, and we're not being accountable as educators.
So building on the topic of technology, there's obviously some relief of the administrative burden of healthcare practice that certainly technology contributes to alleviating. Of course, you've identified a very practical consideration in clinic with respect to technology and in the delivery of healthcare and monitoring, but there's a lot of other realms of technology around data, health data, analytics, cybersecurity, privacy, and then again, technology as the opportunities arise to perhaps liberate and to create better pathways that would address many of those challenges with respect to equity. There is a digital divide as well. So technology certainly looking to the future. I mean, certainly the pandemic has advanced that future to our doorsteps with respect to digital, the digital economy, the importance of data, privacy, and security. But at the same time, technology is wrought with challenges as well. And so, how best to prepare the next generation of clinicians with respect to technology, or prepare society, and so that system-wide, in some respects, to be positively receptive to the use of technology, and in many ways, aspects of technology also create divides where there is an inequity in terms of access to technical supports and digital technologies. So I know it's a lot to frame around, but technology is certainly going to be a big part of the orientation of the School of Medicine. But it's also the future of healthcare. It's the future of our world, and as it is unfolding at this moment. So I just maybe want to explore that a little bit more. So to either one of you to start and lead on that topic of technology.
I'm happy to jump in, Stephen. And the only thing I would say, or perhaps push back on, I know you described technology as being a liberator of administrative burden. And in fact, our studies demonstrate the exact opposite. And so technology has actually been an added burden because of a lack of co-design of that technology with the clinicians who use the work. And so an example of this is electronic medical records. Great, everyone is digitally integrated, although, by the way, we're not, because we have 1,000 different EMRs on 1,000 different systems that don't talk to each other. So that actually makes workflow worse, not better. So we don't have a unified approach to technological and digital infrastructure development. That's a problem. And so when you ask a clinician who's working on the ground in the grassroots, they'll tell you that, in fact, the technology, the click burden that comes with EMRs is a substantial one, and it's actually a leading driver of burnout, not an alleviator of burnout. And so when you have an absence of stakeholders who are using the technology, and you're being foisted upon the technology being foisted upon them without thoughtful co-design, you're going to run into problems, not only with adoption, but then the rollout and then the efficiencies that come therein. And so this is sort of a bigger analogy, or at least perhaps a metaphor for how we think about the future of healthcare as we think about digital tools that come along with, right? Pre-pandemic, we talk about virtual care. There is virtual care is here to stay, but what is the version of virtual care, and what is the appropriateness of virtual care in certain contexts? That still has to be determined. And once again, it has to happen with collaboration of frontline physicians and other clinicians and other healthcare workers to make those choices, as well as make those determinations. So for example, I'm a physiatrist. I see patients with strokes and spinal cord injuries, catastrophic injuries. I also treat patients with muscle, bone, and nerve injuries. So if someone comes in to a clinic of mine and they're complaining of knee pain, well, I can't do a physical exam through a screen, right? I need to be, your knee pain might be an ACL tear, you might have tendonitis, or it might be garden variety or osteoarthritis or something else. So that there are limitations with technology as far as certain contexts of healthcare provision, but other areas are very, very well suited for virtual care. So we're still developing that understanding globally as a profession in real time. But there is absolutely, nevertheless, technology is part of the future. In fact, it has the potential to be an extreme boon for the healthcare sector, access, technology, anticipation, integration, all of these things. And when I think about digital infrastructure, we have to think about who owns that infrastructure, who is responsible for its development, who's responsible for funding it. And when I think about digital, I think about three key areas. Integration, we talk about digital privacy. So how does the law evolve with things like asynchronous messaging and technology that with using platform agnostic approaches to care? So privacy, and then thirdly, security, right? So the horizontal and future threats of things like hacking and nefarious actors in the space, that is a real concern right now. Newfoundland was hacked, their whole medical system was hacked, and they were seized. Like, they couldn't do anything with their patient care records. And that has a huge impact on the ability to provide care in a timely way. I work in a hospital system that was hacked over the summer, and we couldn't administer Tylenol to folks in the emerge. So you had to go back to paper charts. So what is the digital infrastructure that a 21st century healthcare system requires? And that's something that we need to focus on.
So I might say is that and you're absolutely correct, and it really comes down to design and both user experience and the receptor community with respect to the technology, be it patients, families, and so forth, but also directly with respect to the physician's experience and healthcare experience with the technology. And we're seeing a trend towards design perspectives and user experience being framed in the development of these tools. So notwithstanding the many technical elements that are associated with this around security and other safeguards and so forth, but it really comes down to how do you design these things, and where are the design experts that you bring in that will help to support that interface. So Josephine, before we turn to the questions from the audience, I perhaps give you some last words on technology or other elements around what might be the future of healthcare that the School of Medicine will need to be mindful of and thoughtful of as it unfolds.
And as I said before, technology is not neutral. It's how we use it and how we get to use it, as Dr. Kassem had pointed out. But we have to say that there have been technology that had helped a lot of people, supporting elderly people so that there are equipment that they can be monitored in the community rather than be institutionalized. But the other bigger picture that we had to look at is, as Dr. Kassem had pointed out, who owns the technology and what kind of infrastructure? Because when we look at health spending, there are, there's a defined, definite kind of resources. So who get the benefit out of it? And also there are more and more research that had come out to show that some technology actually are biased because of the kind of machine learning, the kind of data that had put into it, tied to people's skin color, tied to gender, tied to people's racialized background and what area they live in. So I think we need to be cautious, but at the same time, if we can actually build a system where all these disciplines actually work together, I'm actually quite encouraged, because within the last year and a little bit, I had been actually having dialogues with the IBEST Center, and these are all people who are high technology medical engineers that I know very little about, but we have been actually having really good engagement about how do we actually integrate social determinants into technology. So I am hopeful, but very cautious.
Great, thank you so much. So we have a number of questions that have been coming in from the audience, and we'll give some time for those questions to be addressed. And several questions have come from individuals very interested in understanding opportunities for internationally educated professionals and pathways to the practice of medicine, particularly from those who've come outside the country, particularly immigrants and refugees, to practice in Ontario and Canada. So perhaps just before just commenting on the Ryerson perspective on this and what considerations we've been given to the program, perhaps a hearing from Dr. Kasama from the OMA on the pathway to professional practice for foreign trained clinicians.
Yeah, thanks, Stephen. And this is sort of a broader question about what we talked about before, which is a health human resource strategy for the province as it continues to try and meet the demands of a growing and an aging population. And as your audience probably is aware of, the pathway for international medical graduates to become fully licensed can be a circuitous one, but it involves dialoguing and liaising with not only the College of Physicians and Surgeons of Ontario, but then, or any of the CPS medical regulators in respective provinces, but also the Medical Council of Canada, who is responsible for the licensing or at least determining the aptitude of potential candidates to become doctors. Meaning, if you go through residency, you have to do your boards. The boards are administered by the Medical Council of Canada, or the Royal College, or the College of Physicians, College of Family Physicians of Canada. So those are the bodies that really need to be involved in these conversations, because that is the path to licensure. If you can't get licensed, you can't practice medicine in the country or the jurisdiction that you're hoping to. And the medical regulator and the licensing bodies need to be part of this conversation in a collaborative way to figure out whether or not that can happen. Obviously, what we find oftentimes are people who are from abroad will have either been medical students, residents, or fully licensed in other countries. They come here, and then either they're not able to, or not eligible to sit the board exam. So for whatever reason, there are many barriers there, or they have to go through residency again, which again is another barrier. And there are only limited numbers of spots for IMGs for certain types of programs across the province, governed by the Ministry of Health and their allocations to different institutions. And so it is quite a complex conversation, but I believe that the real drivers of that conversation should and hopefully will be the college and the medical licensing bodies nationally.
So thank you. So it's been a big part of the conversation from the start in terms of the conception of School of Medicine at Ryerson. Through the Chang School, we've had a continuing education, have had a program in place to support internationally trained healthcare professionals and physicians, many of whom have found their way into residency positions or into the practice of medicine. Having said that, we are looking through a pathway that would be incorporated into the School of Medicine, perhaps a 2-year program. It would be not unlike some other programs for healthcare professionals in dentistry and medicine and other jurisdictions and schools of medicine that have provided an accelerated pathway to graduating from a medical school program. And while that might add some time, it would create an accelerated pathway to entry into the profession as per the processes and expectations to practice medicine in Ontario, as Dr. Kassam has outlined. So it's a big part of the conversation about how best to support internationally trained professionals, and that we would have a pathway in the School of Medicine to support that. So there is lots of discussion and admissions, and the admissions working group with respect to the background of students. The program is intended to draw students from all backgrounds, from social sciences to the sciences to engineering and so forth. There was one question here, particularly around engineers. And I will say there's been a long history of pathway of engineers into medical practice. That's not been uncommon in my experience both at Queen's, and I have a PhD graduate of my own from civil engineering, and who is now an orthopedic surgeon. So the expectation is that there be some minimum requirements with respect to certain science courses, but also social science courses, as it would be for social scientists to have certain requirements for science courses, as the admission committee works out on some of the basic admission requirements, which are still in development, but it's considering the pathway for students from all sorts of backgrounds, including consideration too with around the MCAT and other examinations that might be used to assess students in entry to the School of Medicine. The intention is to break down some of the barriers that have limited perhaps entry from a diverse pool of students, but the expectation is that students from all sorts of backgrounds with meeting minimum requirements for consideration would be considered for the School of Medicine. I think we've discussed, managing mental health challenges encountered during the medical school training. I know this has been in part discussed with respect to considerations with respect to a 3-year medical school program or 4-year medical school program in one regard, but other considerations and supports as well. But reflecting on both Dr. Kassam and Dr. Wong's backgrounds as students coming through nursing and medicine, thinking back to the supports that you would have liked to seen when you were a student. How are our programs coping and managing with respect to mental health concerns? I know it's been a big topic and subject of focus and in terms of program and supports around wellness, broadly speaking, on our university campuses, but I'm thinking specifically with respect to medical schools and other health care professional programs as well. Are we doing enough to support students, and could we be doing more? So I don't know whether Dr. Wong or Dr. Kassam might want to comment on this, but
I think we can always do more in the sense that our student population is not like uniformed. There are students who might come from a situational context where they have more social support. We also have students who might have contexts that actually make them more predisposed to, mental health challenges and that kind of stuff. And I feel that supporting students' mental health is also part of the medical training, because when students are able to actually experience their own challenges and look at what supported them, then when they go out and become a primary care physician, mental health is not just another topic that is somewhere else, that is actually integrated, and depending on which service user group they are faced with, or they are providing services to, for instance, if they are actually serving sexual minority or people with gender identity issue that's going in, then they need to automatically see the person as a whole person and think about the kind of needs. There are on-campus mental health support, but I feel that a lot of times it's also the structure of the education itself. The kind of stress that we put onto students. Do we really need to make education so stressful that this is almost like the old traditional way that you torture students, and if they succeed, then they must be excellent? And I disagree with that. There has to be room for people to go through education and recognizing their passion, their commitment, but at the same time relating to themselves. And the other part that I just want to add on is that about international trained physician. Yes, we need to talk to all the colleges and associations that grants people the licensure to practice. But every single one of us as citizens, we have the power to go and change something. And that's the grassroots movements that we need to do, regardless whether we're going into medical school or we just care about the healthcare system. So I just want to add that part in.
Great, thank you very much. So there's been a few questions, particularly around diversity and equity, and particularly with respect to the makeup of the medical class and the future of our clinicians, and really about lowering the barriers that have historically limited individuals from pursuing careers in medicine. And I just say at the outset that embodied in the School of Medicine is this commitment to equity, diversity, and inclusion. It's a strategy for the School of Medicine. And so in our academic planning processes is the equity, diversity, inclusion strategy. It begins with thinking about a pipeline of students from the community. It's about the admissions process. It extends to the composition of the faculty complement and leadership, and the resource allocation that you embed in your program to support initiatives around equity, diversity, and inclusion, and committing to that systematically throughout the program, and as well as the way in which we're engaging in our communities and diverse communities as well. So I think that this is really a commitment. It is a promise. And from the conversations on admissions as well, with respect to ensuring that we're generating a pipeline, and with respect to a diverse pool of applicants, and drawing people's interest in School of Medicine, even from coming at an early age where people don't necessarily see the opportunity and only see the barriers. There's a lot of work to be done, and I will commend existing medical schools for making significant changes. And while this it has been slow to change and so forth, we are committed to building a medical school really founded on that commitment to equity and diversity and inclusion at all steps in the discussions around our academic program, our support for students. And one of the most important of the barriers is really around socioeconomic conditions, and which have been obviously plague a disproportionate disproportionately groups of people, and largely racialized individuals and immigrants, others, First Nations and Indigenous communities, and that have been huge barriers of entry and support as well. And so it's a very important consideration, and it's not really a consideration. It's intentionally to build a medical school with this firm commitment at the outset. Clearly, with our orientation to community-based health, with withdrawing from clinicians in the community, getting our clinicians to work in the community during their training, and retention of individuals in those communities will be very important to ensure the appropriate culturally respective and support and drawing individuals from the communities in which they serve, and having them continue to serve in those communities will be an important consideration as well. So there's a lot of extent practices and changes that have occurred that we're learning from, but we're also intentionally building a school that will be fully committed to this at all stages in its development, its implementation, its execution, and sustainment going forward. With respect to specializations in mental health, and which is another area that was identified in one of the questions. So primary care is a big focus of and community-based health, but within the practice of medicine, and I'll certainly ask Dr. Kassam and Dr. Wong to comment, but envisioned in here is a postgraduate residency opportunities that are clustered around those areas of specialization relevant to primary care, and mental health is a big part of that, as is our support for aging, population health, obstetrics, gynecology, emergency medicine, and a wide variety of different specializations. And so there's significant emphasis being placed in the focus on mental health, in the not only in the context of the issues we've discussed already about students, but also in terms of the orientation to practice. Dr. Kassam, perhaps beginning, if you wanted to comment about some of the areas of specialization, particularly around primary care, that are particularly important and for which there are gaps to be filled.
Yeah, thanks, Stephen. It's a good question. We know, and I said this sort of at the beginning with my remarks, 1 million people in the province of Ontario don't have access to a family doctor. We know that family health teams and collaborative team-based approaches to care work better for the patient in terms of navigation, access to resources, outcomes, and ultimately, quality of life. What we are finding a challenge with right now, and again, this goes back to system factors. You can create, so right now, new residents who graduate from a family medicine residency in the province of Ontario can't enroll in or can't join a family health team or family health organization. So these are patient enrollment models. This is a problem because you can have a training program that extols the virtues of a collaborative-based approach. But then if you have a physician who graduates and can't enter a team like that, then what's the point? And so this is where, again, focusing on system-based factors is going to be very important. And we should be having expansions of these types of models that we know that work very, very well. Our organization has been very clear that physicians should have the autonomy to choose the type of practice that they believe would best serve the communities that they serve. We know that the previous administration, provincial administration, actually capped that enrollment model. So, and in fact, the previous administration cut residency spots to family medicine, neurology, and obstetrics and gynecology. What some of the key areas you just mentioned, they cut them. So when we think about how do you get more with less, right? You can't, that's not a recipe for success. And so when you think about building a program and then ultimately wanting to have it deliver on the goals that you've set out, then you have to involve other system level partners to make decisions that are beyond the scope of a 4-year election cycle. And so this is where I think, Dr. Wong talked about the political economy. That's sort of where having an understanding, but also an influence and being able to shape decision makers is going to be very important.
Great, thank you very much. So we come close to the conclusion of the hour we set aside for this conversation, which I've enjoyed very much. Josephine, I'll give you just if you wanted 30 seconds, if you had one last comment to make.
Yes, I see the proposed medical school as a school of possibilities. So when we talk about possibilities, that means that not only the faculties, the university, but every single one of us who are in Ontario can do something about this. And tied to what Dr. Kassam just said, we don't have to just accept the system as it is. We can go and change the system. It's hard work, but it's possibility. So that's what I want to end.
Great, thank you. I know that we haven't had time to address all the comments, but I know that quite a range of comments, particularly with respect to diversity, racism, sexism, ageism, anti-faith, poverty, and homophobia, and certainly recognizing the need to address some of the systemic barriers and lack of diversity in the medical profession and in the practice of medicine as well. So I just want to acknowledge those points. And it's unfortunate we don't have time to address everyone's questions. It's been a wonderful conversation, and I'll turn it over to Krishan for final concluding remarks. But thank you, Josephine, for so much for your contributions and sharing your thoughts with us. Over to you, Krishan.
That's great. And look, what an incredible conversation. And clearly, this is just really the beginning, and another conversation needs to be had, maybe perhaps several with our community. And so Dr. Liss, thank you so much for curating this conversation. Dr. Kassam, Dr. Wong, your leadership and expertise in these domains just matter so much to shaping this future. And to your point, Dr. Wong, about the possibilities for systemic change, I think this is really not just about education, but exactly that. And so with that, I am so grateful on behalf of all of us at the university and for our alumni community in particular, but also all of our friends tuning in. Thank you for sharing your time and leadership and perspective on this. We will have an additional conversation. It's so important to all of us, and look forward to that in the new year. And to all of you who've tuned in, thank you for making the time to do so, and look forward to more opportunities to connect, not just on this topic, but many others that we host across many domains and subject matters at the university and beyond. Looking forward to that in 2022. So please stay tuned. Look out for a recording of this conversation so that you can share and rewatch with your networks and friends in the coming days. And until then, happy holidays and wish you all the best, and look forward to seeing you all again in 2022. Be well, be safe, and we'll see you again soon. Thank you, guys.